So the highly myopic eye, this patient has an axial length of about 28 millimeters. And many such eyes are sensitive to elevated intraocular pressure. So in this case, we've lowered the infusion pressure on the phaco machine to 50, 50. Little sting. And now we'll put some viscoat and fill the anterior chamber. And there's a prominent Bell's phenomenon that's probably going to disappear as the sedative takes more effect. So because of the Bell's phenomenon, I'm just going to control globe position with my left hand, namely with the spatula. Deep, very deep chamber. So far not too deep, and we'll see when we put the phaco tip in if it's too deep. Because rarely we have to inject the vitreous cavity on highly myopic eyes in order to reduce the chamber depth so that we can actually see. And we'll do hydrodissection here. It's going to be a soft lens, and I'll bet even with an IOP of only 50, which doesn't force a lot of the lens material into the phaco tip. Because the pressure differential between the inside of the eye and the inside of the phaco tip is what pushes lens material in. So here we have our IOP of 50. I'm quite sure that if we were higher, he'd be squeezing and wouldn't like it. Quite sensitive, I can tell already. Okay, so we're not going to be able to chop this lens, I can tell. I mean, look at that. Go right through it with the chopper. So let's now go to quadrant removal.
Quadrant removal.
So the soft lens technique here, just aspirating the periphery. If the lens rotates like that did, it's going to be a cinch. If it's too soft to rotate, well then you might even just take it out with an INA tip. So this is just hand over handing it, if you will. So we didn't need to use any ultrasound here. And we're ready for INA. So in this 45-year-old photosensitive, highly myopic eye patient, we just kind of used more gentle parameters. And then of course we need to use this. You need to either sedate them a lot or center them with your left hand, because so many of them are, when they're photosensitive, will just be unable to look at the microscope light. There's some subincisional cortex there. I'm going to protect the posterior capsule as I kind of tease it out. Let's do that and turn the eye toward me. So now we've just got that, and remove some epithelium from under the anterior capsule. And now we're ready to put in OVD and then the IOL. So here we're injecting the cohesive viscoelastic into the posterior chamber, expanding the capsular sac and gently rubbing the posterior capsule as we do that to get off a few little lens fibers or epithelial cells that are back here. And again, always do this while injecting. Never do it dry. In this young patient, when I use multifocals in young patients that have very significant distant vision demands, as many of them do, wet the cornea, please. You're going to feel some water on your eye. Okay. I like the Restore 2.5 active focus lens, so-called, because of the aspheric monofocal design of the central optic. So I'm just encouraging this to unfold into the capsular sac there. I think the trailing haptic didn't make it. Now, nor did the leading haptic, interestingly enough. I think I can tuck that one in like that. The trailing haptic I'll dial in here in just a second. And I think I'll do it while I have the INA tip in the eye, because of his Bell's phenomenon. Here we go. I can control the globe position better here. Okay, there we go. Just tuck that in to the capsular sac. Now I'm going to remove OVD from behind the IOL here by prying up the IOL with the spatula, but I'm not removing it from in front, because I think if we do, we'll very likely have a flat chamber. He's been Bell phenomening and squeezing and etc. And that's why we lost OVD during IOL insertion. Okay, so before I do anything else, I'm going to do stromal hydration, close incisions, see if I can get him to look down. Barry, look down towards your shoes. Just enough to make it there. Okay, now I'll see what OVD I can irrigate out. I'm positioning his globe. You can see how I've got the cannula on the left side of the incision there. Okay, I think that's about all the OVD we're going to get out by irrigating here. And that should be fine. One more depression here to get some escape. And then fill it again. And we'll check his IOP in about an hour, since we know we've got some OVD left there. Look down. And that looks good there. Every so often you'll see the tiniest little seepage, and if you hang around for a minute, it'll stop. Once you see it stop many times, you usually don't hang around for a minute anymore. But that's now dry. That side port is still seeping ever so slightly. If you look at the red cells, you can see them kind of moving away. A little tiny amount of flow. Okay, so you could hydrate that again if you wanted to. His IOP is nice and steady. But I'm going to tell you, that one is just not going to continue to leak. In fact, it just stopped. So here we have the highly myopic eye that we had to manage Bell's phenomenon with photosensitivity. Phaco done with a low IOP of 50 and the soft lens technique.